So again, ACL is intrasynovial, origin is lateral, insertion is anterior and between the intercondylar entrances of the tibia. I said earlier that you have an anteromedial bundle that is tight in flexion and primarily responsible for the anterior plane function of the ACL. PL bundle is tight in extension, and if you want to test the PL bundle, you do the pivot shift. So when the knee is flexed to 30 degrees, the ACL provides 87% of the restraint against anterior transmission. Nakalagay dito, I am muted now. Sir, hindi ginagamit na mic sa computer. Okay. So, again, let's place from the middle, geniculate 90% type 1 collagen and 10% T3. Native ACL provides, the tensile strength of a native ACL again is 2,200. Pag bone container tendon bone, it's 3,000 Newton. Kapag quadruple hamstring autograft, 4,000. ACL, the mechanism is a non-contact pivoting, and it is often associated with a meniscal tear. If you are talking about the ACL, letter L, ACL, associated meniscus is the lateral, letter L. Pero if long-standing ACL deficient, it is more commonly associated with medial meniscus. Okay. So chronic ACL deficiencies is associated with meniscus injuries, chondral injuries, and arthritis. So ACL plus MCL plus medial meniscal tear equals unhappy triad. How about terrible triad? Coronoid plus radial head plus anterior posterior. Posterior dislocation. The most common direction of dislocation for the shoulder? Anterior. Posterior dislocation of the shoulder you will see is senior and electrofusion. So lateral meniscus is associated with ACL tear. Medial meniscus tear associated with chronic or matandang tear. So sex-related difference, ACL is more common in females due to landing biomechanics. Females get ACL injuries at a younger age, and females get ACL injuries on the supporting leg. Males on the kicking leg. So presentation, these are the things they wanted to ask. If you have a patient suspected ACL tear, there's a felt patient will feel a pop. There is immediate swelling due to hemarthrosis and unable to continue the game. Physical exam, Lachman, if you are doing the Lachman test, you're testing the what bundle? AM bundle, anteromedial bundle. It's the most sensitive exam, grading 3 to 5, 5 to 10, and more than 10 millimeter translation. Okay. A PCL tear may present with a false Lachman because of the posterior side. And remember nga pala, the ACL deficient patient will present with quadriceps avoidance gait. ACL deficient knee will present with a quadriceps avoidance gait, meaning the patient when walking will not actively extend the knee. So anterior thrower, pivot shift, and KT 100 on the other test for ACL. So imaging. So second fracture, this will again represents bony avulsion of the ALL. and associated with 75 to 100% ACL tear. Avulsion of the proximal lateral tibia and pathognomonic for an ACL tear. So number one, simple. Number two, deep sulcus terminalis sign. Depression on the lateral femoral condyle, on the picture on your right, that you can see on a plain sagittal radial. MRI, these are the findings, non-visualization on the sagittal, discontinuity on T2, bone bruising, and an empty notch on the forearm. So treatment, non-operative. There's a room for non-operative management for low-demand patients with decreased laxity. But again, it is associated with an increased meniscal and chondral damage linked to pivoting sports. Operative ACL reconstruction. So in younger, more active patients, children, and older active patients. And if you have prior ACL reconstruction failure, if you have a combined ACL MCL, you allow the MCL to heal first before doing the ACL. Kasi di ba MCL is intracapsular. That's why MCL can heal on its own. Compared to LCL, which is an extracapsular structure, that's why if you have injury to the LPL and posterolateral corner, you either repair it or you can reconstruct it. So that's the difference. Combined ACL MCL allow the MCL to heal and then you do ACL. So if you do ACL with a damaged MCL, there's a increased risk of a rupture. So pag MCL, ACL, allow the MCL to heal. So pag meniscus plus ACL, you do it at the same time. Best timing for ACL reconstruction, normal or near normal range of motion, and a non-inflamed with minimal effusion. Okay? To prevent the most common complication, which is arthropfibrosis. So for ACL repair, high failure rate, so not worthy to remember sa exam, pero there's, di ba, yung bear, and tsaka rotate na naman. So graft selection, you have the bone patellar bone, bone-to-bone healing, highest incidence of anterior knee pain, and bone patellar tendon bone again, 3,000 Newton tensile strength. Maximum load to failure is 2,600 according to Bullets, 3,000 according to Miller. There is anterior knee pain, and aside from that, there is an increased risk of patellar fracture post-op during rehab. Not intra-op, but post-op. So sa quadruple hamstring, ang autograph, smaller incision, less periop pain, less severe knee pain compared to bone patellar tendon bone. And maximum load to failure of a quadruple hamstring autograph is 4,000. There is weakness in extension. Hamstring, you remove the hamstring. And you have the single bundle and the double bundle based on multiple papers, same outcome. Single bundle, yun yung ginagawa natin. Double bundle, you are doing double bundle. You're reconstructing both the AM and the TL bundle of the entities here. Same outcome. Allograft, useful in revisions, longer incorporation time, risk of disease transmission. So assignment, you need to remember yung sa bone, yung bone sa bone grafting, di ba? Kapag freeze-dried, saka fresh frozen. Kapag fresh frozen, meron ka pang, ano yung natitira? Ano yung difference between fresh frozen and freeze-dried? Kapag fresh frozen, you retain the BLB. Kapag freeze-dried, nawawala na. Tama? So, purely structural. So, tunnel placement. So, you remember the numbers. 1 millimeter rim of the posterior cortex of the femur is a back wall. Diba, naalala niyo, pag giving drills, sinisilip natin sa anteromedial kung may natitirang back wall. So, that's the 1 millimeter. And tunnel should be placed on the lateral wall 9 to 10 o'clock. So we do it at 10 o'clock to create a more horizontal graph. Because if you do it at 11 or 12, the graph will be more vertical. And if you have a vertical tunnel, vertical graph, what will happen to your knee post-op? You will have instability in rotation. You will have a rotational instability that you can check. Post-op, you still have a positive. If you want to test for rotation, what test will you do? Pivot shift. No? You have positive pivot shift post-op if your tunnel is too vertical. So sa tibial tunnel, 10 millimeter in front of PCL, medial and posterior to the anterior horn of the lateral muscle. So the most common cause of revision ACL is tunnel, malposition. Vertical tunnel placement will cause rotational instability. If your tunnel is too anterior, you will have a knee that is tight in flexion. Yes, tight in flexion. If you have a tunnel that is too posterior, you have a knee that is tight in extension. So, no, tibial placement, tight in flexion, impingement in extension. So your tibial leads to an ACL that will impinge with a PCL. And yeah, that's the last slide.